up until now. And today we are looking forward to the 7th webinar in the series on congenital anomalies of the kidneys and urinary tract. We have a very excellent speaker today, and we will be listening to her very soon. Before that, we have some instructions for today. Can we have the next slide, Dr.
Yes, sir.
Yeah, as we are moving through the slides, I can tell you that this will be a 60-minute talk followed by a Q&A discussion right after the talk. Whatever questions you have, you can actually put it in the chat box and actually put in the Q&A section. And as we know that, at the end, we will have a polling session. And the polling session is mainly for the trainees. We do have first, second, and third cash prize for those polling sessions. And the instructions for the polling sessions will be provided at the end of the talk. Next slide. Yep, so you want to go ahead, Dr. Uma?
Yes, sir. Good evening, everyone. I'm here. I'm with pleasure introducing Dr. Amrit Jain, sir, who is going to moderate this session. He's a medical director of Pediatric Kidney Transplant Program, Children's Hospital of Michigan, USA. He has received the Teacher of the Year Award, Associate Professor voted by the Children's Hospital of Michigan Pediatric Residents. He has also received nomination for Excellence in Teaching in Pediatrics Award, nominated by colleagues for exemplary teaching at CMU College of Medicine. And also he is been awarded the Top Nephrologist Award, peer review survey of physicians honoring the adult and pediatric nephrologist in Metropolitan Detroit, MA. Over to you, sir.
Yeah, thank you so much, Dr. Uma, for the introduction. And I'm honored to introduce and welcome our speaker for today, Dr. Christina Suzan, who's a pediatric urologist here at Children's Hospital of Michigan. She completed her medical school from the prestigious University of Maryland School of Medicine. She did a pediatric urology fellowship at Johns Hopkins University Hospital. She has special academic interest in cloacal exstrophies, partial pediatric nephrectomies, and hydronephrosis. Dr. Suzan is also in charge of the myelomeningocele clinic or the spina bifida clinic here at Children's Hospital, and she was actively involved in the spina bifida registry in USA. She's also an active member of Society of Pediatric Urology, American Urology Association, and Pediatric Urology Oncology Working Group. She has been named in the Top Doc Award multiple times here in Detroit area. She has extensively published. Her articles you can read in pediatric journals and urology journals. And she most recently published in Journal of Pediatric Urology on grading of hydronephrosis. She's a wonderful colleague, friend, and a great advocate of shared decision-making when it comes to complex pediatric urology nephrology cases. I'm really delighted and honored to welcome Dr. Christina Suzan. Dr. Suzan, it's over to you.
Thank you so much for that warm welcome. And again, good evening / good morning. And I'm going to try to figure out how to share my screen here. Let's see. So I'm very excited to have this opportunity to talk to you all about antenatal hydronephrosis. And I know I'm speaking with a group of highly educated pediatric nephrologists, and I'd like to give you a little bit of perspective on what the pediatric urologist thinks. I have no disclosures. So what are we going to talk about today? First, we're going to talk about how we talk about pediatric congenital hydronephrosis. What diagnostic modalities do we use when we're trying to work up antenatal hydronephrosis? What causes antenatal hydronephrosis commonly, and how do we treat it? So first, how do we talk about it? You know, this is a survey study that was sent to the North American members of the Society of Pediatric Radiology, and they wanted to determine how radiologists do talk about hydronephrosis in their reporting. And as part of this study, they included 3 cases and they asked the radiologists to describe them. 284 radiologists responded, and they found that 2/3 used descriptive terminology. And I'll go into that a little bit further in a few minutes. 36% approximately used SFU grading, and around 36% described it using the AP diameter. Now, to back up a step, they also asked, what do you consider a normal study? And this is specifically in terms of the APD. And they found it was all over the map. So right out of the gate, the pediatric radiologist did not agree on what a normal study is. And this is important. If you have a patient that's coming to see you and they don't bring the images, they only bring a report, all it says is normal. For some of the radiologists, normal could be all over the place. So then they, as I mentioned, they sent 3 cases. So this is the first case that they sent. And with this case, they found that how they described it again was all over the map, whether it was pelviectasis, whether there was an extrarenal pelvis. Now, this is the important part. When you look to see whether it was mild, moderate, or severe, and this is that before mentioned descriptive grading, it was all over the place. And then even using SFU grading, which is an attempt to make it a more objective measure, some people graded it grade 1, some people graded it grade 7, although you can see most were in the grade 2 to 3 range. This was the second case. Again, some of those reading it thought it was moderate, most found it mild or normal. And then this is the one that concerns me the most. So especially if you're a pediatrician that is seeing a report of an ultrasound and you see that it's mild to moderate, that may make you not right away refer to a specialist. So when we talk about what does hydronephrosis mean, it's important that we're all speaking the same language. And now these are some of the systems that are currently used. There's other ones that are in use as well. So again, the descriptive, the SFU grading system, the APD diameter, and we'll go into a little bit more detail about the UTD system as well. So who is using which system varies by specialty, location, and diagnosis. So if you look, again, descriptive, mild, moderate, severe, and then the APD is the maximum diameter of the intrarenal pelvis on transverse images. So you can see that pediatric urologists favor, and this was a study we did specifically looking at the literature and how hydronephrosis is described in the literature. And in pediatric urology journals, we favored using SFU characterization, with the next highest being APD diameter. Pediatric nephrologists, for example, seem to prefer the APD. And it also varied by what the diagnosis was. So in actual manuscripts about hydronephrosis, 25% didn't give any description of the severity of the hydronephrosis. So the SFU system, I do find it very useful for a quick reference when I'm reading my notes. And more simply than those pictures, I mean, the big thing is whether there's splitting of the central calyces, whether it starts moving to the more peripheral calyces, and then finally, the most severe form, you'll see parenchymal thinning. Now, in 2014, a multidisciplinary conference was held at the AUA headquarters where they brought together multiple groups. So you recall from several slides ago, I mentioned how different specialties use different terminology. And this was an attempt to get everyone on the same page, so we'd all be speaking about the same thing. And the goal was not only a unified description of upper tract dilation, but also to come up with a guideline of how these patients should be evaluated after birth. So first, they talked about what is normal. And so they defined normal in the prenatal period. It varied by by weeks of gestational age, and then postnatal, and this is key, greater than 48 hours, having a APD of less than 10 millimeters was considered normal. And you can't have any other abnormalities. This is just looking at, you can still be normal with some dilatation of the renal pelvis, but that's it. So what is abnormal? And again, it depends on where in the pregnancy the evaluation is occurring. So you can have central or peripheral dilatation. They also evaluated parenchymal thickness and appearance, the appearance of the ureters and bladder, and again, prenatally, whether there was oligohydramnios. Postnatally, they took into account the same characteristics. However, they of course left out oligohydramnios. Now, this chart here is also saying how they recommended stratifying the risks. So you can have some dilatation, and including of the central calyces, but no peripheral calyceal dilatation and be low risk. And then the other factors automatically increase the risk. Looking postnatally, they further stratified it into 3 risk groups. Basically, anytime the parenchyma appears, if the parenchyma appears abnormal or the bladder is abnormal, that automatically puts you into a higher risk group. So now, how do we image antenatal hydronephrosis? So the first thing I already alluded to is, of course, renal bladder ultrasound, but it's important that this be performed at the appropriate time. Clearly, if a patient is high risk and you're worried about valves, it's important to know that right away. But if it's isolated antenatal hydronephrosis, particularly unilateral, you're going to get a more accurate ultrasound if you're doing the imaging after 48 hours. And these are the characteristics. Whether or not the UTD system is used, I really like that way of breaking down the important factors to look for on the ultrasound. So again, the APD diameter, whether there's central or peripheral dilatation. If there's any parenchymal thinning, that is important to know, along if there's cysts or increased echogenicity, and of course, bladder or ureteral abnormalities. So VCUG, when do you perform it? These are the AUA guidelines, and this is an old picture, but they're still pretty similar. Basically, if they recommend performing a VCUG for high-grade hydronephrosis, anytime there's ureteral dilatation or an abnormal bladder, or if a patient is being observed and they develop a urinary tract. Now, the observational approach is an option when you're looking at milder hydronephrosis. And this is based off of the fact that particularly for antenatal hydronephrosis, there may not be a benefit to identifying whether or not there's whether or not there's VUR. How I recommend performing it is having the patient awake, that's so that they're actually voiding normally with a normal voiding capacity and pressure. It's important that the bladder be adequately filled. And so at our institution, they typically do at least 2 cycles to make sure that a reflex void at a lower volume isn't missing VUR. And it's especially important to capture voiding in a male infant where you have concerns for valves, because you want to make sure that the urethra appears normal. I will say if there's reflux that's only present on voiding, that's important to know whether you need prophylaxis or if a child is having recurrent febrile urinary tract infections. It's probably less important. It's more likely to resolve spontaneously if there's only reflux on voiding, but still, as we've discussed, very important to see the urethra. It's important that the studies be performed at a constant height of the contrast, as if the contrast is at a higher level, you're more likely to see reflux than if it's at a lower level. And that higher level may be representing supraphysiologic pressures. And if available, a child life specialist is very helpful. Now, in in the patient with antenatal hydronephrosis, where you're doing a very early study, sometimes the child life specialist is more helpful for the parent than for the child, but certainly in older patients, really can make the experience at least tolerable, if not pleasant. And as I recommended grading your hydronephrosis, we also like to grade reflux so that we are able to follow it more effectively. Studies have also shown great variability in reporting of reflux, but I think it's important to, grade 1, this one is very important because if it's not reaching the kidney, you're less likely to have recurrent febrile urinary tract infections versus grade 5, where it's much less likely to resolve spontaneously. And if it persists, it can actually lead to bladder dysfunction from double voiding. And then the gray zone is sort of in between. So you may see some studies referring to it as dilating or non-dilating reflux. And I even think that's a useful characterization. Nuclear medicine studies can be performed in varying situations. So for example, if you have a child and it's unclear whether they have very severe hydronephrosis versus a multicystic dysplastic kidney, a DMSA can be performed to help discern if there's any function. But we typically hold off on performing MAG3 studies until at least 4 weeks. And that is corrected gestational age. This is because in order for the substance to be secreted by the proximal tubules, you need some degree of renal maturation. But the MAG3 study is useful because it not only helps us determine function, but also the drainage curves. And when we perform a MAG3, it's important that a catheter be in place. This enables drainage of the bladder so you can see whether there's distal ureteral dilatation. If there's reflux and a catheter is not in place, it may make you falsely believe there's obstruction when there's not. The child should be well hydrated to maximize the secretion. Some places advocate placing the patient upright, and this allows gravity to help drain. So is the radio tracer collecting in the kidneys because the child's lying flat and gravity isn't enabling drainage? It's a possibility. So I know some centers will place the child on an upright board. And again, because a catheter is in place and IVs are placed, having a child life specialist available can make it a more pleasant experience. So what are the common causes of hydronephrosis? So sometimes it's just that the child's normal. There's no pathology involved. It's the appearance, and it's not going to lead to any increased risk of infection or renal deterioration. The one we worry about the most initially is obstruction. And that obstruction can be from numerous causes. Posterior urethral valves would be the most significant because both kidneys are affected. Ureterocele, ureteral vesicle junction obstructions, ectopic ureters. And for all of these, you would likely see some degree of ureteral dilatation as opposed to isolated ureteral pelvic junction obstructions. And I've left off some of the more rare causes, such as urethral atresia or prudent belly. And finally, vesicoureteral reflux, if it is dilating reflux, can lead to a hydronephrotic kidney. So most commonly, it is that it's the child's normal, that it's transient, it will go away spontaneously, or it may just not progress any further. Next, we see ureteral pelvic junction obstruction as the most common cause, followed by reflux and other causes. So again, posterior urethral valves would be the most severe common cause of antenatal hydronephrosis. And prenatal details that are important to elucidate in your history is whether the antenatal hydronephrosis was unilateral or bilateral, whether there was oligohydramnios during the pregnancy, and how far along in the pregnancy before birth. The first concern is respiratory status, because with oligohydramnios, you may have problems with pulmonary dysplasia or hypoplasia. And next, of course, we do worry about the kidneys, and some of these children will go on to requiring kidney transplants, and some may need immediate dialysis even shortly after birth. As they grow older, there is significant bladder dysfunction, or can be. This is amplified by the fact that it's usually high output renal failure. So the child is making more urine into a bladder that's been affected by obstruction. Early on, we will commonly see high pressure bladders and often prescribe like oxybutynin, for example, to decrease the bladder pressures. However, as the child enters puberty, it just kind of gives up the fight. The bladder tuckers out and it's unable to effectively squeeze and can become atonic. So these bladder problems, they do not go away, and these patients do require lifelong follow-up by urology, in addition to, of course, lifelong follow-up with nephrology because of the significant renal injuries. And then finally, the ureters are also affected, and you can have secondary ureteral obstruction, both from the thickness of the bladder or from just not being able to squeeze effectively to transport the urine. So we start by obtaining a postnatal ultrasound, and this is one instance where I don't want them going home and getting it in a week. This is something that should be performed in the hospital, and if there is clinical suspicion of valves, a VCUG should be formed right away. MAG3s can be useful if you're worried about a secondary obstruction. And recently, I know one of my partners had a patient that developed a secondary ureteral pelvic junction obstruction from ureteral tortuosity. So MAG3s can help figure out if there's an obstruction and where it's located. And DMSAs are sometimes helpful if, like, for example, if there's a child that's having recurrent infections and you just want to know whether it's contributing any function at all or what the degree of scarring is, DMSA can be helpful. So on ultrasound, of course, you would see hydronephrosis. You'd likely see ureteral dilation, and the bladder itself will appear abnormal. And there's the classically described keyhole sign with the dilated posterior urethra. On VCUG, there may or may not be reflux present. And in my anecdotal experience, sometimes the reflux is not there initially because of the secondary ureteral vesicle junction obstruction, but on repeated filling cycles, you may see reflux. And then these bladders can be incredibly beat up and even have diverticula present. And on nuclear medicine studies, again, it depends on whether you even need to perform it. Urodynamics can be very helpful in guiding therapy in terms of whether or not a child may benefit from adding an anticholinergic, also just to track their function. So some children, as I mentioned, will develop an atonic bladder. Some will have very high bladder pressures early on, and especially when you're considering a transplant, you will want to make sure that the bladder health is maximized should the child reach that point. So this was a patient that the mother had somewhat limited antenatal care. And so he actually presented with a urinary tract infection when he was between 2 and 4 months of age. You can see his right kidney is hydronephrotic, and you can see this fluid collection outside of his left kidney. And it turned out that he had had a fornicele rupture. Oh, here's the dilated ureter, and this bladder is very irregular appearing. So on his VCUG, you can appreciate the bladder wall thickening and little cellules of contrast. This was the drain that was draining that fornicele rupture, and the reflux on that. He had unilateral reflux. And then this dilated posterior urethra, this tight bladder neck. So placing the catheter initially, and I personally recommend putting in a feeding tube, not a catheter, but it can be somewhat challenging because there is this high bladder neck. Now, ureteroceles are a type of ectopic ureter with a cystic dilation distally. And when you're looking at an ultrasound, you will just see this bubble inside the bladder. And if you can have bilateral ureteroceles, you might have 2 bubbles in the bladder. They are commonly diagnosed prenatally, although occasionally an infant girl may have a mass at her introitus, and it can be a prolapsing ureterocele. Typically, we think of ureteroceles as being the upper pole moiety of a duplex system, although single system ureteroceles are possible. You may remember from your embryology the Weigert-Meyer rule, where the upper pole ureter is going to end up inserting more medially and distally than the than the lower pole. So this is another picture of what it would appear like. And on ultrasound, you would have hydronephrosis. You may or may not appreciate a duplicated collecting system. So for example, if there's hydronephrosis limited to the upper pole and the lower pole parenchyma looks normal, that's pretty obvious. It can sometimes be more subtle than that, or if there's occasionally the ureterocele can obstruct both ureters, so you can have severe hydronephrosis of both moieties, or there may be severe reflux leading to lower pole dilation. The ureter will appear dilated, and there can be this cystic space in the bladder. I should mention, this is if it's going to be a clinically significant ureterocele. On occasion, as part of my training, you do an adult urology residency followed by a pediatric urology fellowship. You'll occasionally see adult patients that have small ureteroceles that were never diagnosed and never problematic. On VCUG, ideally, you'll obtain early images, which will demonstrate a filling defect within the bladder. However, sometimes the ureterocele will extrude out of the bladder wall because there's a more thin detrusal layer there, and so it'll appear as a diverticula, and you may or may not have reflux either into the lower pole moiety or into the ureterocele itself. And then MAG3s, if it's a small ureterocele and with minimal dilation that's not progressing, sometimes a MAG3 can help you determine whether or not you even need to treat it at all if there is obstruction. The other time a MAG3 can be helpful here is if you're trying to determine whether to preserve the upper pole or whether the patient would benefit from a heminephrectomy. So in this ultrasound image, you can appreciate the degree of hydronephrosis in the upper pole versus the lower pole is different, with much more marked upper pole hydronephrosis. And on the imaging of the bladder, you have a dilated distal ureter, and you can see this thin-walled ureterocele right at the ureteral vesicle junction. On VCUG, on early imaging, you have this bubble on the right side there. However, it is a thin-walled ureterocele, and it becomes effaced with filling. So they can be missed if only later images are captured. Or sometimes if the bladder is not completely drained at the time of catheter placement, it may be effaced even at the start of the study. So moving on to ureteral vesicle junction obstruction. So the classic description is that you have this megaureter, this ureter that's massively dilated. And there are 4 potential causes for a megaureter. It's very easily broken down into non-refluxing, non-obstructing. So this is a patient that won't require any sort of treatment ultimately. You can have a refluxing, obstructing megaureter, so both reflux and a blockage. And then you can have non-refluxing, obstructing, or you can have refluxing, non-obstructing. So doing your VCUGs and your MAG3s is key to determining which type of a megaureter you're dealing with. They can be primary versus secondary. So for example, a patient with posterior urethral valves may have both refluxing, obstructing, any combination, but it's important to note that it's a secondary megaureter and a secondary ureteral vesicle junction obstruction. Primary UVJs are more common in males than females, and they can resolve spontaneously. The thought is that there could be a non-synchronized squeezing of the muscle fibers within the ureter, so the urine isn't adequately propulsed forward, and those can resolve spontaneously. Now, there is also a risk, however, that function will be lost due to urinary tract infections, in which case treatment may be necessary. So on ultrasound, you would see hydronephrosis along with ureteral dilation. If you do see bladder wall thickening, be concerned for something like either a neurogenic bladder or valves. On ultrasound, on VCUG, you may see reflux if it is an obstructing, refluxing megaureter. And MAG3s can help you determine whether or not you need to operate. So this was a child with antenatal hydronephrosis, and you can appreciate this dilation of the left kidney. Although you can also, I think, see here nice corticomedullary differentiation. There's no thinning of the parenchyma there. And then if you move the ultrasound probe down, this very dilated, tortuous ureter. And going all the way down to the bladder, you abruptly lose where that dilated ureter is. And then on VCUG, this child did not have any reflux. And ultimately, he did undergo first a ureterostomy for having infections, and then ultimately a ureteral reimplant. We'll talk about those in a little bit. Ectopic ureters, similar to with a ureterocele, can either be single or duplicated system ureters. And we typically think the more unusual the location of the ureteral orifice, the greater the degree of the renal dysplasia. So, for example, an ectopic ureter may not even ever cause any problems. It may just be sitting essentially on the trigone, might not have any obstruction at all. You can have an ectopic ureter into the bladder neck, which will have near normal function. But for example, Dr. Jane and I share a patient that had an ectopic ureter into his seminal vesicles and essentially had no kidney. The presentation varies by gender. So with girls, they will often present at an older age with constant incontinence because of the ureter inserting into the vagina. Boys will never present with incontinence per the urethra. Both of these pictures, by the way, have rectal ureteral orifices. That's not something I've ever seen. I'm inclined to think that would be exceedingly rare. But boys might present with recurrent epididymoorchitis from it inserting into the seminal vesicles or near the male sexual ducts in the prostatic urethra. Oh, sorry. There we go. So on ultrasound, you can expect to see hydronephrosis. You may or may not see a duplicated collecting system. You will see ureteral dilation. And again, you might even be able to see the ureter entering into the vagina and having vaginal fluid. Sometimes you can have reflux associated with it, particularly if it's a duplicated system. There may be reflux into the lower pole moiety. And if it is inserting into the bladder neck, this is another time it's important to capture voiding, because at baseline, the bladder neck muscles are contracted, so there may not be any reflux, but when the bladder neck relaxes to enable micturition, you may have reflux occur. And again, the MAG3 can demonstrate whether there is function and if there truly is obstruction. And the function is particularly important here because with some of these ectopic ureters, you end up with a segmental multicystic dysplastic kidney, and then you're really not going to do anything versus a system that's obstructed but has function and may benefit from early intervention. So right out of the gate, I want to point out that this case I'm presenting to you has myelomeningocele. So already the bladder is not normal. But he had an ultrasound performed, and the initial read of this ultrasound was just hydronephrosis. And you can see there was significant ureteral dilatation down at the level of the bladder. But then when he had his VCUG performed, this degree of ureteral dilatation does not match that. And so it became very obvious that we were dealing with a duplicated collecting system. And I chose this image to show you because think it was even pretty obvious then. You can see a lot of thinning of the upper pole moiety, but nice lower pole parenchyma. And so, yes, he had an ectopic ureter. And when you are trying to determine, and this is true with the ureterous seal as well, when you're trying to determine the function or obstruction, it's important to look at both the upper pole moiety and the lower pole moiety. And so you can see here the upper pole does not drain, and then you can see the elevated T1/2, but it did have some function here. The lower pole had more function, but the upper pole did have about 36% function. Ureteral pelvic junction obstructions are most commonly now identified through prenatal ultrasound, particularly if it's an intrinsic obstruction, but children and adults may present symptomatic later in life. And again, the intrinsic obstruction, sometimes this can just be discoordinated squeezing of the muscle fibers, and it may improve spontaneously. However, if there's a true area of narrowing, that is not going to go away. And that's versus extrinsic pathology with a crossing vessel going to the lower pole. This is sort of a pet peeve of mine, saying that it's obstructed versus partially obstructed. If it was totally obstructed, there would be zero function. So really, any of these where there's any function at all, it is a partial obstruction and not a complete obstruction. And so it's important to determine the degree of obstruction and whether or not function is being impacted. And the management really depends on the clinical situation. So on ultrasound, you will have hydronephrosis with or without cortical thinning. And on ultrasound of the bladder, you should expect no abnormalities. You can have vesicoureteral reflux just as a concomitant finding. I mean, some studies have quoted up to a 40% concomitant reflux rate. And then on MAG3, again, you want to confirm whether or not there truly is an obstruction and what the function is, whether you need to intervene early or whether it's someone who can be observed. So this was a child with antenatal hydronephrosis, and she had a VCUG performed, and you can see with the reflux on the same side, the contrast does not make it into the kidney. You can't say this is grade 1 reflux, however, because if you can appreciate that the more proximal ureter is actually dilated because it's just not making it past the obstructed ureteral pelvic junction. And then on MAG3, you can expect to see a delay in the drainage. And this kidney did have, despite having nice parenchymal thickness, did have a decrease in function and required a pyeloplasty. Reflux is a very common diagnosis. It's not always linked to having antenatal hydronephrosis, though, because up to 15% of infants with a normal prenatal ultrasound may have at least transient reflux. And it's thought to be caused by having insufficient muscle backing of the ureteral orifice. So with the ureteral orifice moving more laterally along the wall of the trigone. In the first year of life, it's more common in males than females, likely secondary to that longer urethra and changes in bladder dynamics over time. Females ultimately are more likely to have reflux. And just as with ureteral vesicle junction obstructions, it's important to determine whether it's primary reflux or secondary reflux. If it's primary reflux, it only really causes a problem if the child, and by a problem, I mean renal damage, if the child is having infections. If it's grade 5 reflux, even if they're not having infections, it still can impact the health of the bladder. With secondary reflux from, say, myelomeningocele and having high bladder pressures, that is a bigger problem because those pressures may directly impact the renal health. And most patients do not require operative management of reflux. They'll resolve spontaneously. And most are not diagnosed because of antenatal hydronephrosis, but rather because of febrile urinary tract infections. So on ultrasound, you may not even have any hydronephrosis at all. You might see some renal asymmetry or renal scarring. For more with dilating reflux, you'll see ureteral dilation. If you see bladder wall thickening, that should be a red flag for it being secondary, not primary. On VCUG, you can expect to see, of course, reflux by definition, but you should not see any bladder or urethral abnormalities. And DMSAs are helpful when determining how to manage reflux because it helps you figure out whether or not there's scars and what the differential function is. So this was not a child with antenatal hydronephrosis, but I think these are nice pictures. This child had recurrent febrile urinary tract infections. And when looking at the DMSA, they take images anteriorly and posteriorly. So anteriorly, the splint function was normal. However, posteriorly, you can see actually they did not have a symmetric split function. And the right kidney actually had less function. So for it to be the child's normal, this is a diagnosis of exclusion. They may or may not have hydronephrosis with ureteral dilation. And by definition, they don't have reflux and they have normal function. I put an asterisk next to no obstruction because ureteral pelvic junction obstructions can resolve spontaneously. Okay, and then I am not going to go into great detail here because it is beyond my area of expertise, but at a lot of our conferences recently, there's been increased talk about computer learning and using and deep learning segmentation to more accurately describe hydronephrosis and predict treatment. This goes back to what we were talking about early on with the ambiguity in describing hydronephrosis and knowing how severe it really is. And in this model, what they were doing is creating a ratio looking at the hydronephrosis area to renal parenchyma. And eventually, with computer learning, the computer itself can determine how much of the kidney is hydronephrotic versus how much renal parenchyma there is. And you may be able to come up with a better way to predict who will require treatment and if treatment is required early or not. And that is a nice segue into treatment. How do we treat it? So clearly, many of these patients should be managed by you guys and by the pediatric urologists. And I really am grateful that Dr. Jain is around and his colleagues because we work in conjunction very nicely together. Our areas of expertise are different, and you guys will see patients that don't need surgery and that you are perfectly fine managing. And then if something changes, you send them to us and vice versa. If I have a child that has a decrease in function in one kidney, for example, I'm always going to have them evaluated by pediatric nephrology to help maximize their renal health. I used to put all of these patients on prophylactic antibiotics because of some studies that suggested even in isolated antenatal hydronephrosis, they can prevent recurrent infections. However, there was a pretty recent study that only looked at prenatal hydronephrosis, so was not really looking at patients with reflux or with hydroureter, and they identified uncircumcised males were a bigger risk for having recurrent infections, as were females. But when they looked at whether or not antibiotic prophylaxis helped prevent infections, really didn't seem to in any group, even those at a higher risk for infections. And I did just allude to the fact that patients that were uncircumcised had a higher rate of infections overall. And so circumcision may be helpful to prevent infections in patients with antenatal hydronephrosis, particularly if they have reflux. And this was a study that looked at patients with reflux, of whom 66 of 308 were diagnosed on screening. And half of the patients ultimately had a urinary tract infection. Those who had congenital reflux nephropathy were at an increased risk of infection, but so were those who were not circumcised. And we know that having early urinary tract infections increases the risk of new renal scars. So they concluded that the greatest risk for boys was having an infection in the first few months of life. And these can occur even if they're on antibiotics, and the circumcision may prevent scars. It's obviously not going to help with dysplasia, but for new scars. So some patients may benefit just from observation, and typically we'll see this with reflux, with ureteral pelvic junction obstruction, ureteral vesical junction obstruction, assuming that function is preserved out of the gate. Now, this was a child who had right prenatal hydronephrosis, and they had a MAG3 study which showed symmetric function. And even though for me, I use 45, 55 as my limit for what is symmetric function, you can see that kidney did not drain really at all. I mean, the T1/2 was predicted to be 69 minutes. And I will consider 20 my upper limit. 10 is the true limit of normal. 10 to 20 is a gray zone. Over 20 is quote unquote obstructed. Although in this child, again, so it's nearly 70 minutes, but the hydronephrosis totally resolved and they never required any intervention. So they can resolve, again, particularly if it is a matter of like discoordinated muscle contractions at the UPJ. And then we can see the same thing with ureteral vesical junction obstruction, so they can be observed. And sometimes small ureteral seals can also be observed as can ectopic ureters. But the question becomes, what is the best way to follow these patients? And you have to go through your own risk-benefit ratio and what resources you have available and what the family is able to commit to. The nice thing about ultrasound is it's non-invasive, there's no radiation, and it costs less money than, say, a MAG3 study. MAG3, however, demonstrates function. Now, if the MAG3 does not show obstruction, clearly following with ultrasound is safe. However, some patients in this study that was looking at patients who had both ultrasound and MAG3, 13% of them had stable or improved hydronephrosis, but ultimately had worsening renal function. And so I will, particularly if it's SFU 3 or 4 hydronephrosis, if they have symmetric renal function and a stable ultrasound, I still like to repeat a MAG3 at some point. And, when to repeat VCGs can be up for debate. You certainly don't need to repeat it within a year. And because of the radiation and discomfort, I've tried to extend it to 2 years or after toilet training. Does laterality count towards your decision of whether or not to observe reflux? In this one study of 98 patients that had bilateral mild antenatal hydronephrosis, and that was 41.5% of all patients with mild hydronephrosis. Most of them resolved in the first year. Very few had urinary tract infections, and of those who did, none of them had reflux. So it really isn't necessary to do any more invasive studies if it's mild, if that's the only finding. This was a study I came across that was recent, talking about using stents to treat hydronephrosis. And the hydronephrosis, the reason I put it in quotes there is because it was varying causes of it. But right out of the gate, I'm a little bit suspicious because the average renal function across all of the renal units that they were studying was 51%. So you might be able to argue, did they actually need anything? But this is showing the percent drainage for each of the 25 renal units that were stented. And they had included 34 renal units. In 6 of those, they were unable to place a double J stent, 4 of whom ultimately required surgery and 2 who were followed conservatively. In the 28 patients where they were able to place the stent, 9 required surgery. So they claimed 19 patients were successfully followed. were successfully treated only with stent. Again, questionable. If function was preserved, it may have just improved on its own anyway. Now, of the 9 where it failed, 7 had increasing hydronephrosis or worsening drainage on follow-up nuclear medicine studies, and 2 required surgery because of complications such as UTI or stent migration. And so even looking at the patients who were successfully treated with a double J stent, 2 of them had grade 2 hydronephrosis at the time of stent placement. So I would just caution, this is not encouraging me to use a stent as treatment, and I think they're best followed either via observation or through definitive treatment. So for valves, those require immediate treatment, and for most infants, that will typically mean ablation of the valves. Now, sometimes if their urethra is just too small, we'll have to do a vesicostomy or other sort of upper tract diversion, such as ureterostomies or pyelostomies. And there are some children where you ablate the valves and they're voiding well and the valves are adequately ablated, but just the pressure necessary for the child to void impacts the renal health. So on occasion, we've done vesicostomies and shortly after valve ablation, that as the bladder health improves with drainage, we're eventually able to take down the vesicostomy. And these patients very clearly need you guys to follow them closely and then us to follow them for their bladder health. We typically incise ureteroseals when we identify them. And that's classically described as using like an electrode or a bug bee to put a hole in it. And in this image here, you can see the hole is distal to where the true ureteral orifice is, and it's in a dependent location, so the urine can drain out. You want to avoid, of course, getting the actual ureteral orifice. And many of these patients describe reflux. Develop reflux. One of my partners considers it a success if they have reflux, because that means that it was adequately incised. But despite whether or not it's adequately incised, especially if they have reflux, they may go on to requiring reimplantation. And for larger uteroseals, they may need their bladder necks or their bladders reconstructed as well. Some may require an upper to lower ureterostomy, where we connect them as we would with, say, an ectopic ureter. And some will require a heminephrectomy if they're having recurrent infections and they have no function. There are other ways of incising ureteroseals besides using the bug bee. This is using an actual resectoscope. And then there's this thing called the watering can technique, where you use a laser fiber and you poke multiple little holes into the ureterocele. This is thought to lead to less reflux, at least in some hands. And for the patients that do undergo incision of the ureterocele, it's variably successful as a single surgery. In this study, they considered the transurethral incision to be effective if that was the only surgery they needed. That would be more commonly seen if it was a single system, because patients who had preoperative reflux often went on to requiring ureteral reimplantation. For ureteral vesicle junction obstructions, most do not require surgery. Predictors of requiring surgery include an increasing ureteral diameter. So the larger the ureter, the more likely you would require surgery. And similarly, higher grades of reflux hydronephrosis were more likely to require surgery. Clearly, if the function is decreased, then treating it becomes more important. And they will sometimes resolve altogether the hydronephrosis. However, this study found that the ureteral vesicle junction obstructions, if you're following them conservatively, they're unlikely to resolve after about 3.5 years. So it may be beneficial at that point if it persists to treat it. So again, if it's a mega ureter who's not having infections, there's a normal split function. You treat it via observation with or without prophylactic antibiotics. However, some require diversion, which can be an early ureterostomy. And I favor doing that because the baby bladder is relatively small, especially if you have a massively dilated ureter. And so you physically could not create a non-refluxing reimplant for some. So you may temporize with a ureterostomy, which will preserve function and have the dual effect of allowing the ureter to decompress and become smaller for the eventual reimplantation. If the ureter is still enlarged, then we will sometimes taper it when we're reimplanting it. And what I like about this picture here is it's showing you this tiny, what looks like a tiny ureter distally, but the actual lumen itself is not obstructed. Like that stent is going through it, but it's showing that it's just not able to squeeze effectively. Most of that difference is from not having detrusor there. So with ectopic ureter, if there's some function, you may be able to preserve it by treating it surgically. Certainly, if the child has continuous incontinence, then you would treat to stop that. And then what you do is highly variable. At one of our meetings a few years ago, they had this battle between two experts. Do you do a ureterostomy or a reimplant, or do you just remove the upper portion of the kidney? And so you'll find people that are firm believers in either approach. If there is no function, then heminephrectomy is certainly a reasonable option. Otherwise, this is a picture of a ureterostomy, you can take the obstructed upper pole moiety, remove the distal ureter, and then anastomose it to the lower pole ureter. This is only recommended in general if there's no reflux, because otherwise you'll just reflux into both moieties. If there is reflux into the lower pole moiety, then you can do a variation of a double-barreled reimplant, or sometimes you can combine it. You can do a ureterostomy and then just reimplant the more normal diameter of the lower pole moiety. Ureteropelvic junction obstructions, we treat with surgery if there is either an impact on function or if they're having symptoms. And in this study where patients were originally treated with observation, if they were going to fail observation, it typically became known by 37 weeks. And then those who in this group that were followed that did not have surgery had been followed for a mean of 54 months. And on univariate analysis, the predictors of needing surgery were the APD diameter, the cortical thickness, the SFU grade of the hydronephrosis, and what the differential function was. And then on multivariate analysis, it was the APD and the preoperative differential function. And I just want to place a caveat to studies like this. So as a surgeon, when I'm evaluating what studies are useful, it's not necessarily the best endpoint to say need for surgery, because something made these people choose to do surgery, and it was probably this preoperative differential function. So take it with a grain of salt. But they did find that having an anterior posterior diameter of 24.3 millimeters or 2.43 centimeters predicted a need of surgery. This was a recent study that's trying to come up with a more objective measure for predicting it. And it's very hard to see. And this is obviously from their publication, but there's a little green line there. So this kidney here had a pyramidal. They were measuring the thickness of the renal pyramid, and it's about 2.5 millimeters. And this one is about 5 millimeters. And they found that patients that had a pyramidal thickness of less than 3 millimeters, if the ultrasound was after 3 days of life, or those where the pyramidal thickness decreased between a second ultrasound and the third ultrasound, predicted a need for pyeloplasty. So that may be something useful. Again, having obstruction and an abnormal split function, for me, is an adequate indication for surgery. Sometimes they may have preserved split function, but they might have flank pain, they may develop stones, may have hematuria. And certainly if the split function decreases or the hydronephrosis worsens, I would recommend surgery. For smaller infants, this may be a pilostomy until the ureter is big enough for reconstruction. However, even in newborns, you can often successfully do a pyeloplasty. And my standard has been for infants to do an open dismembered pyeloplasty. So basically you cut away the area of obstruction and then you anastomose it. The robot can be useful even for, I mean, there are people that will do a robot assisted pyeloplasty even in infants. I definitely favor it in school age and up patients and can very clearly see this crossing vessel. Some would argue that the robot is a better surgical approach in general because you're less likely to miss a crossing vessel, but crossing vessels are also much less common in smaller infants. So this was a patient that had normal prenatal ultrasounds, but as a teenager, he had presented with flank pain. With VUR, we treat it with antibiotic prophylaxis, typically at least until toilet training. After toilet training, my practice has been in a child that's stable to stop the antibiotic prophylaxis and see how they do. And I follow them with repeat ultrasound. And for the VCUGs, if I had a patient that had a febrile urinary tract infection at 2 months of age, and then I'm seeing them back, they're doing well on antibiotic prophylaxis, I typically try to wait 2 years before repeating the VCUG. And then let's say at 2 years, the reflux persists. If they're able to stop antibiotics after toilet training and don't have any further infections, for girls, I repeat a VCUG when they're, 5 to 7 years of age to see whether or not it resolved. For boys, I'm happy. If they're not having infections, I don't repeat a VCUG. And my indications to operate on a patient with reflux include having 2 breakthrough infections. So that is an infection while they're taking their prophylactic antibiotics. If they have renal damage and the parents just strongly prefer doing some surgical intervention, I think that's reasonable. But evidence of renal damage in and of itself is not an indication for surgery because they still may outgrow it. For girls, I like to see them outgrow the reflux. We don't have any good studies that show reflux during pregnancy actively causes complications. We don't have good studies showing that, but we do know that women, when they're pregnant, are more likely to develop urinary tract infections. And so it's certainly reasonable that this could lead to complications later on. And I have heard of the anecdotal evidence. What we do know is that renal scars increase the risk of having preeclampsia. So when I do have a child that had a DMSA that shows renal scarring, I always counsel the parents to let the child know so that they can let their obstetrician know later on to follow them more closely. And some parents just absolutely do not like antibiotic prophylaxis, and that's reasonable. Dr. Jane alluded to, I feel very strongly that in shared decision making, both with my nephrology colleagues, but also with the parents. And then options include cystoscopic injection of subureteric materials such as deflux or reimplantation. And so if you are going to inject, there are other agents available now. The only one that I've ever used is deflux. You're going to inject it to kind of bulk up the ureteral orifice to make the actual hole smaller. But the other thing it does is it can actually increase the length of the tunnel. There's varying approaches for reimplants. They can be performed inside the bladder. That's the classic way with, if you guys have heard of like the Cohen cross trigonal. It can be an extravesical where we never open up the bladder. And I do not recommend extravesical if it's bilateral reflux because you can damage the nerves going to the bladder. They sit right near the ureteral vesicle junction outside of the bladder. But for unilateral reflux, I think it's great because if you're not opening the bladder, you're less likely to have hematuria or like bladder spasms. And then both of these approaches can be performed either open or laparoscopically with or without the robot. And so this is an example of an intravesical. So the bladder is open and you're lengthening the tunnel so that when the bladder is filling with urine, it can compress the ureter and hopefully decrease the risk of reflux. So in conclusion, when you are talking about reflux, when you're, talking about hydronephrosis, when you're documenting it in the notes, find your own consistent approach. That way you're able to quickly assess from looking at your last notes what the degree of hydronephrosis is and whether or not it's improving or worsening. This is especially important when you're following patients over time, and certainly if you are writing a manuscript, I encourage you to describe it as closely as possible. The mainstays of imaging for hydronephrosis include, for us, ultrasound, VCUG, and MAG3. And the possible diagnoses really boil down to obstruction, reflux, or the child being normal. And the treatment can range from observation to major surgery. However, most patients will have normal kidney function and most will not require surgery. And with that, I thank you all for your attention.
Yeah, thank you so much, Dr. Suzanne, for such an excellent talk. And this was great, a review of all the causes of antenatal hydronephrosis, how to approach them. And thank you for sharing all the wonderful pictures of the patients and, the different renal scans, the VCUGs, your approach to surgery. This was excellent, so we really, really appreciate, all your time and all your explanations for this. I would request the audience to keep on putting questions in the Q&A section. I do see some questions popping up, and we will take them one by one. And to start with, I have a question, Dr. Suzanne, and I wanted to, say that a lot of times what happens is the neonatologist, when there's a history of antenatal hydronephrosis, they would do the ultrasound right away. The baby is just born and somehow they are so nervous, and they would order the renal ultrasound, and then either urology or nephrology gets consulted pretty much, within like few hours of birth. You did mention about the timing of the ultrasound, and can you talk a little bit more about, which kids we can wait for the ultrasound till 48 hours or 24 hours, which kids can actually get ultrasound, after discharge also. So if you could share some of your thoughts with the audience about that.
Yes, thank you, Dr. Jane. That is a great question. My biggest concern if the ultrasound is performed too soon is the parent can be falsely reassured or the pediatrician can be falsely reassured. I do not need to tell this audience that urine production is going to ramp up in that first 2 days of life. So you can have an ultrasound that is normal at birth, that actually the child has a ureteral pelvic junction obstruction. The renal kidneys just haven't started making urine yet because of the relative dehydration at birth. So the ones that I feel can be safely, and not only safely, it's safe to do it later, but it's actually safer to do it later, would be a child with unilateral isolated hydronephrosis. Even unilateral hydroureteronephrosis, if the actual renal parenchyma appears normal, I think that can be safely and is safer to image later. Mild to moderate bilateral with no other abnormalities, I think you're probably better off waiting 24 hours for that same reason. The time when I think it is crucial to get it right away is if you either have other abnormalities such as renal cysts. We had a patient at Children's who I know who, if you look at his first postnatal ultrasound, he had no hydronephrosis, he had valves, but it was very obvious that he had something seriously wrong. I mean, he had echogenic kidneys with cysts and a thickened bladder. So in a patient like that, it's very important to do it early on.
Yeah. No, thank you so much. I think those are very good.
Add one other caveat. Thank you. I'm sorry to interrupt you, but the other time that I think it's, if you really think the family is not going to follow up, if you can get it right before discharge, get them as old as possible. I know all of us operate in different systems where parents may have different access to care or ability to follow up. An ultrasound performed at 47 hours of life is probably better than one that'll never be performed. So sorry. Thank you.
Dr. Amaresh, I have a question to Dr. Susan.
Yes,
Dr.
please go
Amaresh,
ahead.
First thing is, madam, the present day we have what called point of care for the neonatals. They always go around about not with a stethoscope, but with an ultrasonogram thing. So anything they start scanning and so they don't stick to the rule of 48 hours. Second thing,
Right.
I could catch you. Suppose an adolescent girl comes on with a grade 3 to 4 reflex with no history of UTI. What would you advise her? Would you advise a surgery or you would ask her to follow up?
I'm sorry, how old is the girl?
It's an adolescent girl.
An adolescent girl with grade 3 to 4?
Grade 3 to 4. She comes to you with a reflex. There's no UTI. Currently, recently, there's been no UTI. What would you advise her?
I mean, again, I always recommend shared decision making, but for me, I think that girls with reflux that persists into adolescence should be treated because I worry about potential pregnancies. Now, on the flip side of that, I would also say if they're very hesitant or they don't want to do surgery, because who knows? I mean, maybe they never even want to have a child, then why are we doing a surgery and they're not having any infections? I go through the signs and symptoms of infection with them. And even though I said earlier in this talk that you can't have renal damage without infections, I'm not 100% sure that's true. Every once in a blue moon, you'll have a child come in that is not having active infections who has a decrease in function. So if they don't want to have it treated, I do think they should at least be followed by nephrology or urology.
Even a normal ladies are prone for UTI in just before their marriage and during their so these children are more prone for UTI. They may not have children, but their life will be visible with recurrent infections. So that's why I was asking this question. Thank you so much.
And exactly. And that's why I want to make sure you raise an excellent point that after girls become sexually active, that's when they will have infections. So if an adolescent girl does not want to have surgery, yes, it's very key to educate them about the signs and symptoms of infection so they get it treated promptly. Thanks for the question.
Thank you.
Yeah. Thank you. And, continuing the topic of UTIs and VUR, the first question, which is from the audience, it says, when we should do DMSA scan to monitor risk of CKD in patient with VUR? So basically, what would be the indications to do DMSA in a reflux patient?
For me personally, and we're really lucky at Children's, we have not had the shortage of DMSA that I know other hospitals have had. My preference is to get a DMSA study 6 months after their most recent febrile urinary tract infection. I like to get a study, at least in all girls, for the reason that I mentioned earlier about concern for renal scarring. It also helps me guide therapy. So if it is a patient that has had 2 breakthrough infections on antibiotic prophylaxis, my personal recommendation, if there's any evidence of scarring, is to do a ureteral reimplant, not to do deflux, because I didn't go into this, but deflux has declining efficacy over time. So even if you have a VCUG that proves that the reflux is cured, a big study performed like around 2010 showed about 20% of those patients will have recurrent reflux. So I use it as part of my operative decision making. The reason why we like to get it 6 months after infection is because that allows the scars to form. It'll give you a more adequate idea of whether or not there is a scar. I typically do the bottom-up approach. So I usually will start with a VCUG, but there's a whole nother approach that has been demonstrated to be effective where you want to identify the scar first, because if you do a DMSA and there's no scars, even if there's reflux, it may not be clinically relevant. But if you do see a scar, so some providers or urologists, nephrologists may prefer to start with a DMSA.
Yeah, and I think the practice has changed also. I know when I was training in India, that was more of like doing a DMSA first. Even in acute settings, the DMSA was being done, and it was routine to follow up after febrile UTI 3 to 6 months later, do a DMSA scan. Dr. Namarwar, you can speak of the changes which have happened now in the last few years. My understanding is, again, even in India, I think now it is more of a bottom to top approach, that DMSA is not the preferred test. First, we go with the VCUGs, and only in select cases where there's recurrent UTIs, when you want to demonstrate reflux, or when you demonstrate scarring, then you would do a DMSA. So love to hear your opinion, Dr. Namarwar.
I'm a lover of DMSA. So in fact, about 10 or 15 years ago, we published a paper, the value of DMSA in urotract infection. We said when you have a certain patient with high temperature and parameters do not support the diagnosis of UTI, but your clinical suspicion is there, you could do a DMSA zone. We found a good percentage of children who had a fever and no evidence of UTI, but when DMSA was possible. Of course, there you must use your great discretion doing DMSA, and you cannot do randomly for every patient or child where you suspect the clinical evidence and some suspicion like urinary positive self counts or etc. Then you do a DMSA. So I also tend to believe this bottom dot thing. But except for me, all my colleagues here in India don't like that. They advocate a standard protocol as you suggested. And then we have to confirm to what the general opinion is. So I also yield to that.
Yeah, no, thank you for sharing that, Dr. Namarwar. And I think that's why we have these conferences, to learn from each other and learn the different practices. It is being done in different continents, and even within the same practice, how differences can be there. I think it's good to learn that. And continuing with the reflux topic, I'm going to take actually the last question, which says, do you give prophylactic antibiotics to all grades of EUR? Some studies had discouraged its use in lower grade. Does that not increase risk of infection? So should routine prophylaxis be advised for all grades of EUR?
I think it depends on, for me personally, it depends on the age of the patient. That's something that I keep in mind. I mean, even if you have a 2-month-old that's diagnosed with grade 1 reflux because of a febrile urinary tract infection, I would still prophylax them. Like, who knows if it truly is grade 1 reflux, if they voided too soon in the study, if they didn't actually capture voiding, if that's what it looked like afterwards. But if you're doing it because of antenatal hydronephrosis, so if you have a child that has that it was caught on screening, I probably would not prophylax for grade 1. And again, I generally there's shared decision making, even for higher grades. Some parents really don't want to give antibiotic prophylaxis for other reasons. So there is, of course, a risk of antibiotic resistance. And I don't know if that's what the second half of that question was getting at. So does giving antibiotics sort of increase the risk of infection? There have been follow-up studies to the RIVER study that show that over time, even if you develop antibiotic resistance, you lose it. So you get repopulated with normal bacteria or bacteria with normal resistance patterns. So that doesn't factor that much into my personal decision making. While we're on this topic, I apologize, I'm not really familiar with the antibiotics that are typically used in India, but my preference is to give nitrofurantoin as prophylaxis when babies are old enough here, because you don't use it to treat pyelonephritis. So even if you develop resistance to it, it doesn't matter. It doesn't get renal penetration. But it does concentrate in the urine. So if you can prevent the infection with it, and there also seems to be less rates of developing resistance to nitrofurantoin.
Yeah, no, I agree. I think, for low-grade reflux, when there is no UTIs, even I would not put them on prophylaxis, and I would wait and watch. Definitely, as we know, in US, the bacterium resistance has increased so much, and nitrofurantoin does become a good choice for us. Dr. Namarwar, your thoughts on that?
Oh, I agree with you. I agree with you. I don't differ from what you say. The only one point is the grade, low grade reflexes, grade 1 and 2, but they're associated with bladder dysfunction, like holding up urine. Then there is caught. Should you give a prophylactic or not? What do you say about that? You have a child.
Well,
reflection.
I mean, that is a great point. And again, because I didn't really focus on VUR in this talk, but we all know that bowel and bladder dysfunction and reflux are very closely related. If I had an older child with say, grade 2 reflux and BBD, I would treat them with prophylaxis more than likely because they're at a higher risk for infections. And then during that time, I aggressively treat the bowel and bladder dysfunction because sometimes the reflux will resolve on its own simply by treating the bowel and bladder dysfunction. And certainly if it doesn't and you need to intervene, it increases the likelihood of success, particularly if you want to do an endoscopic treatment for the reflux. So that is an excellent point, that it's very important to discuss bowel and bladder dysfunction. The other thing, if you look at a 6-month-old that's diagnosed with reflux, I mean, they don't have bowel and bladder dysfunction yet, but they're at an increased risk of developing it later. So that's important to keep in mind too.
Thank you. Thank you very much.
Thank you. And in that relation, there is a clinical scenario which has been brought up by one of the attendees. The patient is a 9-year-old boy, well to date, incidental finding of an episode of balanitis and right mid-pole renal scarring. And I'm thinking this is on an ultrasound. The right kidney is 50th centile, left kidney is 75th centile, normal bladder, no UTIs, normal creatinine, normal blood pressure. The question from the attendee is, do I proceed with a DMSA? And do I need to look for scarring in that case? Yep,
so if that patient came to see me, I'd actually send them to you. If they've never had a urinary tract infection, I would say, we'll see what our nephrology colleagues say.
Yeah, no, and I agree. I think, that's what even I was thinking. This is more of a question for a peds nephrologist. And frankly, I would not do a DMSA on this particular child. Somebody who has no UTIs, normal blood pressure, normal creatinine, right kidney at the 50th centile, the left at 75th centile, with some ultrasound finding of right mid-pole scarring. I would just monitor clinically and then see. I think the attendee is worried that could this be a dysplastic right kidney instead? With a right mid-pole scarring, the chances are less. And I think I would just monitor and I would not do a DMSA. Dr. Namarwal, I would love to hear what you would do.
No, I would do the same thing. I would think in terms of a possible hypodysplasia kidney. I'll keep a long-term follow-up and see what is happening to the biochemistry. For about 17, 18 years, at that point, will tell us what we're dealing with. So I think at that point of time, there's no need for a DMSA. But the routine regular ultrasonogram will be of great use.
Yeah, great. Thank you so much. And we'll switch gears. We have a question on transient hydronephrosis. And if I understand this question correctly, I think the attendee is asking, when can we discharge patient with transient hydronephrosis? And I'm thinking that is from the clinic. So.
I think that there is not like a definite study that proves this. My personal approach is I always at least repeat one ultrasound following toilet training because I wonder if the changing bladder dynamics with voiding could change the degree of hydronephrosis. But if I have mild hydronephrosis, I don't even always get a VCUG or a MAG3, but if it remains mild, I get a study, that initial study at birth. I usually repeat one between 3 and 6 months. If that's the same or better, I repeat one at a year. And then let's say at a year, it's totally gone. Like there is no hydronephrosis. I still will repeat one after toilet training. So that's what I use as my guideline.
Yep, no, thank you. And then we'll talk a little bit about UPG obstruction, and there are a couple of questions on that. So again, the question is, how long children with UPJ should be followed up with stable function? So very similar question like transient hydronephrosis, but this is related to UPJ. Although Dr. Pradhan doesn't say whether this is post-pyeloplasty or whether it is, just a UPJ which is being monitored clinically. I think we can try to answer both ways, post-surgery and then maybe who has milder UPJ.
So starting with a milder UPJ, this is a great chance for shared decision making, because if you have a documented obstruction and you've proven this with a nuclear medicine study and they're 5 years old and they still have a documented obstruction, my concern here is that they could be at risk for developing renal stones, even if they don't have a decline in function. And this is also a child, like when they get older and they're drinking like cupfuls of coffee and they're making more urine, they are at risk for developing pain. So this for me is, if it is not getting any better and they're school age, it's a good opportunity for shared decision making. And I know that we've discussed, so at our hospital, we have this wonderful conference where it's like the nephrologist, the radiologist, and the urologist. And we've often discussed parents that are just anxious at the thought of getting ultrasounds for their child's whole entire life. And what about when they're an adult? Are they going to maintain their follow-up? So I think a lot of times parents would prefer to have an actual documented obstruction treated if it's not getting better. Now, you raise a good question with post-pyeloplasty. A lot of these patients with more severe hydronephrosis, particularly if you don't do, and I don't do a reduction pyeloplasty, it's not been shown to improve the outcomes, and it does increase the risk of like developing a urine leak after surgery or scarring. You will often have hydronephrosis after the procedure, as long as it is getting even slowly better, or even if it stays as bad, but you repeat a MAG3 and there's no obstruction. I typically continue to follow them with ultrasound to look for a change. And then let's say you have a study that shows preserved function even years out, but there is decrease in drainage. I do recommend treating it for the same reasons I just said. I would do a redo pyeloplasty because of concern for stones or developing symptoms later on.
Yeah. No, I think that sounds great. And actually you answer the next question also, which says about a post-pyeloplasty follow-up with a MAG3, what should be in the long term, how long they should be followed. And I think that answers what you said, that if it's worsening, then they may need to repeat MAG3 and then
that's when you do it.
Well, so thank you for that. And then I'm going to switch to a couple of questions which are more related to minor abnormalities in the kidney. And I'm summarizing those two questions together. How do you follow, or how do you approach patient with lower port dilated calyx with DMSA showing no scar? How do we approach? How do we follow them? And then there is another one which says, how do we follow kids with extrarenal pelvis? Minor abnormalities of the kidneys, and then we may not need any intervention, but how frequently do we follow? How do we approach them?
So an extrarenal pelvis, I treat the same as mild hydronephrosis. Like if there's no change after toilet training, I think they can be discharged safely. Similarly, if it's isolated minor lower pole dilatation, you would have to have some concern that there could be reflux there if that's why it's isolated to that place. You can also have with a duplicated collecting system, a lower pole ureteral pelvic junction obstruction. Doesn't sound like it from what the audience member is questioning. I would typically do the same thing. I mean, after toilet training, if there's no increase and they're not having any infections, I don't think you need to get a VCUG for an antenatally diagnosed mild calyceal dilation.
No, I think that sounds great. And that covers actually all our questions. And this has been a very interactive and very, enlightening discussion. Dr. Namarwar, any other questions that you would have?
No, I don't have questions. Thank you. I would like to thank Dr. Susan for a wonderful webinar. It's a great eye-opener for most of us. Thank you very much.
Yeah. No, this
Thank
has been
you all for having me.
Yeah, this has been an excellent discussion. Thank you so much, Dr. Susan, for your time and all your explanations. And I think it's 10:30, so we are right on time. We will move on to the polling session. So Dr. Suzan, again, thank you so much. You don't have to stay back for the polling session.
Thank you.
And Dr. Uma will take over the polling session. Thank you so much.
Thank you, sir.
Thank you.
Thank you.
Participants are requested to enter proper email ID and contact number during the process of registration for the ease of future communication. Totally, there are 10 questions and you have duration of 6 minutes, and we'll have 3 star questions in each session. And star questions are taken into consideration in case of tie. Cumulative score of all 10 polling sessions will be taken as a final mark for selecting the winners. So good luck to you all. 1 more minute.
Okay. I think the time is up now, and thank you once again for everybody joining for this wonderful session. And we will look forward to the next session, which would be on Wednesday, and we'll have some excellent speakers for that day as well. So thank you, everybody, and thank you, Dr. Uma, for running the show today, and thank you, Dr. Kalavani, for joining, from far. This should conclude the session. Thank you, everybody.
Thank you,
Thank you,
sir.
Dr. Uma. Bye.
Bye,
Thank
sir.
you.